My topic is a very basic, a clinical approach to neurological diseases. The reason I choose that topic is uh, just to uh, I'm just trying to move to the another slide. How can I do that? Right, okay. The reason I choose this topic is because of a lot of people has a neurophobia and they thought neurologic is a difficult, but it is not. I hope I can change your mind and attitude and concept about a neurological disease. It's no different from the general medical diseases. Of course, the approach is slightly different, but general principle is the same. So I will go back to the basic. Even in the well-developed country, Western Europe and America, you cannot ignore the basic. However scanny you can have, however fancy investigation you're going to available without a basic clinical skills, you're not going to get anywhere. So the good clinical approach remains pivotal. And I'm not talking about individuality of the management. I think it is a was mistake. I will probably talk the general principle of the management. There's a in practical, if I want to teach about management of the epilepsy or management of the stroke or management of the Parkinson's disease, it's not going to have a time. And I will leave any details to the book or internet. I just want to give you a concept rather than the factual knowledge. As far as you are using internet, as far as you are not using Mindtel, I am happy. Okay. Now, getting the diagnosis, again, it's only 3 to 4 lines: history, physical examination, and investigations. Plenty of the treatment, again, the same. Plenty of the treatment started from history, physical examination, investigations, and treatment. History will tell you what is the potential diagnosis. Uh, History will tell you the differential diagnosis. History will tell you the prognosis as well. And also history will guide you what suitable treatment this patient may well have. Let me give you the example how history can guide through to get the treatment. For example, if the someone come to see me epilepsy, if she is 32 or 33 years old female and that she want to have a family, I would use sodium valproate. Even it was for the juvenile myoclonic epilepsy. However, someone, young man, very severe epilepsy, and I would probably use sodium valproate. That's why the history is important. Another case is, for example, if the someone got the SLE who developed the stroke, you would have probably used the antiplatelets because of the potentials of the thrombocytopenia. So the history is very, very important. Now, physical examination. If the someone already gone, for example, let's say ulnar neuropathy, all the interosseous muscles are gone, patient has already contracture in his or her hand, I'm not going to refer for the elbow operation. I'm probably going to refer for the cardiac surgery in the hand. So that's why history and physical examination is important, not only the getting diagnosis, but also the formulating the treatment. The same principle applying for the investigation. For example, someone got a metastatic brain tumor, you probably not going to offer the radical operation. Probably you might offer radiotherapy or chemotherapy, depends on the tumor. So every step you think about it, history is not just taking history per se for the sake of it. By taking history, physical examination, you are thinking ahead. That's also the same for any general medical condition. And proper neurological examination begins with a careful clinical history, because in the neurological examination, you don't have a time. And especially, I know doctors in Burma, you're probably going to see 5, 10 minutes. And here, we have the luxury of the seeing new patient for 30 minutes and follow up for 15 minutes. So in the limited time, you can't see everything and anything. If the someone come and see you, I got a numb dose, why do you need to take the mini metastate score, for example? So neurological examination also guided by the clinical history, and also look at the patient. If the patient is telling everything, but for example, patient is dysarthric, when you are talking to the history, or patient cannot express the word finding, and the dysphasia, whether this patient has an expressive dysphasia, and therefore the careful clinical examination always started with the clinical history. And people with the dementia, they normally neglect self-care. So unless they have a well look after relatives or spouse, and they are dirty, the toenails, fingernails are also long and unkempt. But if the someone come to your clinic on their own with the well presented, well dressed up, and if she or he is complaining, I got a memory problems, doctor, it's most likely concentration problems rather than the cognitive problems. So proper neurologic examination start with a careful clinical history and look the patient, the whole atmosphere. Okay, next slide, please. Now, good neurological history can be very revealing. Actually, he is or she is giving you a diagnosis, and also he or she is giving you how you're going to treat. For example, if the someone's telling you, I'm sold my car to see you a doctor, you're not going to prescribe the fancy drugs for the minimum benefits. So you have to think about patient lifestyle as well. And also you need to listen. And if you do not get the diagnosis after halfway through the history, it is unlikely you will get the diagnosis, to be honest. And once you got the diagnosis, I rely on history most of the time. So don't be apprehensive just because you can't get the MRI scan, just patient cannot afford CT scan of the brain. If you do proper neurological history and physical examination, you can help the patient a lot. For the history, and I want to emphasize about temporal profile, and that's mean time of the onset, frequency of the events or events, and the evolution of the symptoms or disease. What I mean, let me get into a bit detail. Time of the onset. In theory, acute onset is less than 5 or 6 days or 2 weeks is acute, whatever book you read. So normally from 0 hour to 2 weeks or possibly 6 weeks is acute illness. After 6 weeks, you probably would say chronic. However, I want to be more precise in the acute onset. As you know, 0 hour to 6 weeks time window is too long. So you have to quantify how acute is your acute, right? How acute is your acute? Um, I want to classify hyperacute onset and acute onset and subacute onset. That's my opinion. Okay, hyperacute onset is just happen a split second. Acute onset maybe a few minutes to a few hours, and then you got the acute onset for a few days to a few weeks. Okay, now why I am splitting the hair? Because it is pathologically, etiologically significant among the onset of the illness. Hyperacute onset always tell you a vascular, for example, stroke, TIA, wrist drop due to the vasculitis. That is hyperacute onset is telling you vascular. Okay, and then acute onset is most likely inflammatory. For example, encephalitis, Guillain-Barré syndrome. They are sort of the optic neuritis. The best example is optic neuritis. If patient developed, let's say, embolization from the atrial fibrillation. I know in Burma, we have a lot of the rheumatic fever, atrial fibrillation, mitral stenosis. And if the patient developed embolization, if the patient developed the blindness, whether it is an optic nerve or the occipital lobe, they are very sudden, right? But the patient develop optic neuritis is normally a few days to a few hours. Patient developed acute onset of the weakness, most likely stroke, hyperacute onset, most likely stroke, but patient developed neurological deficit within a few days, most likely encephalitis. So that's why onset is important, because treatment you're going to offer will be different. Then the chronic onset, it's probably again some inflammatory, like a chronic meningitis cases, indolent meningitic process, or maybe slow growing tumor, or maybe degenerated disease. The best example is like dementia, Parkinson's disease. They are gradual, slow, declining onset. So that's why onset is important. If the patient, for example, another example is, I'm not going to apologize for giving so many examples on the onset, because it is extremely important. Another example is a headache. Someone come to see you, I had a headache, as if someone hitting my head with a hammer, split second, is most likely subarachnoid hemorrhage. You better do lumbar puncture if the headache is within 7 days, or you better do the scanning CT angiogram. However, someone say very sudden onset, and you're going to ask the patient how sudden is sudden. And well, I was very well this morning. I don't feeling very well, and I was preparing for the food to my kids before they go to the school. And then a few minutes later, I started getting a little bit of the pain in my head. Within 10 minutes, I have a most excruciating pain. So if you listen to the story, it started with a minor level of the pain, and it evolved into very severe pain within 10 minutes or 20 minutes. It's most likely migrainous headache in principle. Okay. Now, frequency of event or events. Some frequencies are intermittent, for example, like epilepsy, if the patient developed deja vu phenomena intermittent, is most likely epileptic temporal lobe epilepsy. And also like a migraine, if patient develop progressive migraine over the 6 weeks period, they never had a migraine, you probably want to do the scan. However, someone is telling me I always have a migraine, I always have a headache on and off. It's worse when I am stressed or when you are the period or sometimes no aggravating or relieving factor, just habit from time to time. It's unlikely any underlying serious pathology, provided that you do not find any red flag signs on the examination. When I am saying it, not all your patients are rich to get the scan. Not all your patients can afford to stay in Manly or Rangoon to wait for the scan. So some very poor patient, you might not have the luxury to arrange all the investigation, everything you wanted, because you have to think about patient budget. But on the other hand, I don't want you to be worried too much. Oh, do I miss the brain tumor? Do I miss any sinister pathology? But if you take a proper history, you will be less anxious. You will be less worried about the patient well-being. So time course of the symptoms, I have already talked in the third bullet. And now jargons. People say some always say different words in the different meanings. For example, in here they say giddiness, dizziness. I have no idea what they mean. So I normally ask the patient, can you tell me what do you mean by that? Or can you describe me rather than using one word? If you feel dizziness, are you feeling lightheadedness? You see star in the sky or black spot? Or are you feeling everything spinning around, everything rotating, the room rotating? So you have to quantify. And also, in the some Burmese terms, for example, Gong ông tông tông yi gong jet there, gong mu there, gong out there, hide there. I don't know what they are actually meaning. So you have to be very precise. For example, hide there does not always mean you have a pulmonary disease or cardiac disease or anemia or myasthenia gravis. If the someone say hide there more, if they can lie in the flat without any more hide there, it's unlikely diaphragmatic paralysis. Therefore, it is unlikely myasthenia gravis. It is unlikely significant heart failure or respiratory failure. So you have to ask the patient what the word they are saying to you. So you need to communicate effectively. Next slide, please. Now, the history drug, and especially in the West, anti-cancer medication, because a new anti-cancer medication can develop all sorts of the neurological disease. And especially we call it an immune checkpoint disorder. But for in developing country and you still got that chemotherapy, so they may develop a peripheral neuropathy, for example, and also people do use indigenous medicine. Some of the Burmese medicine can have a mercury, lead, so they can develop myasthenia like syndrome, they can develop neuropathy. And of course, the recreational drug like a cannabis or a medication or like a cocaine, and you have opiate, you have to ask. And genetic, uh, ask the family history, ask the family history. And it is important, are you your parents related apart from the marriage, because especially in, I think probably in the old days in the Burmese family, they tend to marry a second cousin or first cousin, and it's more common in the some Asian community like India or Pakistanis. They married like their first cousin or their uncle. So genetic disease is also important. And milestone, and you have to ask, is this person normal? When I say milestone, not only the mental milestone, but also physical milestone. Can he walk? What time he can walk? And even if the patient is telling you, oh, I am okay, and now it's okay within 2 years ago, okay, fine. When you are 20, can you run? Can you play football? When you are in the school, and are you as good as a sport? Most of the men, they break their physical prowess, but I don't believe in them. And travel history, I don't need to do anything in detail. Travel history, you can got a lot. HIV and weight loss. Weight loss is telling you either underlying systemic disease, for example, connective tissue disorder, malignancy, HIV, or severe chronic infection like a tuberculosis. And premorbid personality is important for the patient, especially cognitive dysfunction. Uh, Anybody want to ask? I think I talk a lot. And is there anything you want me to ask? If there is a no questions, I will go to the next slide. Any question? So next slide, please, in that case. Okay. Now, neurological examination is easy, and everybody got nervous, especially when I was in the third year medical students or final part two neurological examination, you got sweats. It's easy, it's easy, and it is very, very easy. Okay. If you have like a plan what you're going to do, and it is easy. So make yourself plan. Let me tell you the plan. How many systems we examined? Basically only four. One is a higher cortical function, another one is a cranial nerves, another one is a motor, another one is a sensory. So mental stage, you can do the mini mental state score, and you can observe, is this patient talking rubbish, or is this patient some inappropriately behavior and to you, and you can got all the information in your outpatient clinic setting. Now, cranial nerves, you got the 12 cranial nerves, but you not need to know everything by heart. You not need to know everything, every step and every details for the working diagnosis. You probably need to do only a few things. I will explain to you in the next slides. And the motor is, as you know, gait and weakness. That's easy. And sensory, okay, you can just touch with a pinprick. You can probably test the vibration sensation. But most important, I would say, is a touch. Okay, so it's also easy. So remember these only four main topic: mental stage, cranial nerves, motor, and sensory. And you remember the first, the initial talk, you don't need to do everything and anything. Your examination, not every patient you can go through all these four systems. So every step also guided by your history. Next slide, please. Now, this is a slightly in detail. And as I said before, mental state examination, like a you can just talk to the patient. You can ask a repetition, like a baby hippopotamus. I don't know how you're going to test the Burmese patient, but you don't want to. You can just talk through it, which one they can pronounce properly, and the memory. And the patient complain of the short-term and long-term memory. And people say that, oh, ဆရာကျွန်တော်အဖေကတအားမှတ်ဉာဏ်ကောင်းတယ်သူအရင်တော့ဟာဒီအကုန်မှတ်မိတယ်ဒါပေမဲ့မနေ့တုန်းကဘာစားထားတယ်ဆိုတာတော့မသိဘူး because if you are going to ask the long term properly, I doubt it. This patient has a very good memory. သူတို့ဘာပဲပြောပြောတကယ်တမ်းကျ long term memory ကိုတည်တည်ချာချာမေးကြည့်လိုက်ဟုတ်ပြီအဖေဘယ်တော့ကအလုပ်စားလုပ်တော့အဖေရဲ့လုပ်ဖော်ကိုင်ဘက်တွေကဘယ်လိုတော့အဲ့လိုမေးလို့ရှင်သူတို့မဖြေနိုင်စေရဘူးနော်အဲ့ကြ memory is a little bit sometimes not every patient. Let me give you my example. And I left Burma over 25 years ago, and I couldn't come back over 10 years, over 10, 11 years. And I miss my late grandma. I miss my late grandma. Whenever I speak to, at that time, there's a no Viber and telephone is very expensive, no Zoom, no Skype. So I can't speak every day. Whenever I speak to my mom, I ask my mom, how is my grandma? And she said, oh, she's brilliant. She is 90, but she is as sharp as a knife. Then I came back to Burma after 10 years, and I haven't. So when I speak to her, and she remember everything, and she remember our old shared memory. She remember what she had eaten. However, what I noticed, she never asked me, what are you doing in England? She knew England. And what is your job? Because I am her eldest grandson, so I don't know how to cook in Burma. If it's a normal circumstances, she would have asked, who cooked for you? Are you married? Or how you eating? She never asked. That is telling me she lost executive function. That is telling me she got the frontal lobe problems. So memory is not just a long term and short term. Okay. Now cranial nerves, I'm not going to get into the detail. The olfactory, you rarely test it. Normally lost, you have a head trauma or just the look and nose problems. And vision, you have to ask a visual acuity and visual field. And sometimes I do test, sometimes I don't. And pupillary reflexes is also important, not necessarily a brain disorder. For example, it can be affected in the Pankos tumor. So someone, for example, have a CA breast, thinly muscles in her hands, maybe the thoracic outlet tumor. So in that case, you might need to test the pupillary reflexes. You're probably going to check the eye movements. So in Bell palsy, you're probably not going to check at the sense of the smell. So there is a list for the minimal test you can do for the cranial nerves. And the motor, you have to look at the gait, how the patient walk. Patient is walking in a foot drop, high stepping gait, hemiplegic gait, ataxic gait, Parkinsonism gait. So you have all sort of the information. And pronator drift, I don't think I can show you because that's no video. And if you can share, if I can, what normally do is you stretch your hand in the pronation position in front of you, as if someone holding the tray with the elbow extended, and ask the patient to close arms, and the hand turn inward, not dropped, hand turn inward. It's called pronator drift. It is a very sensitive, a subtle sign of the primitive trick, such as a stroke. Okay, and then you ask the individual muscle strength, and you go for the reflexes, you go for the sensory, and that is for the summary for the neurological examination. But it does not mean you have to do everything. That has to be guided by the history. Next slide, please. Now you have so many tools. You don't need to use everything. And even if you are cooking, you have a salt, you have a white pepper, you have a black pepper. For example, you have a oil, you have a butter, you have an onion, you have a garlic. You're not going to use everything and anything in every cuisine. So the same. So for me, I use only tender hammer, ophthalmoscope, and pinprick and cotton wool. The rest is not really important. Next slide, please. So that is a summarizing what I have already told you. You must do a minimal basic examination. That does not mean you have to do formal examination. As I said before, when you started talking to the patient, you know some of the system you have already examined. Okay, you don't need to do every test. Next slide, please. And I think I'm not going to repeat. And examination is guided by history and general observation. Now, don't forget the general medical examination. For example, a patient may well have a hepatosplenomegaly with a multiple cranial nerve palsy. It may well be lymphoma. Okay, and patient may well have a abnormal lymph nodes in the lung, cervical glands. It may be the lung tumor spread to the brain and ovarian tumor. So general medical examination like a mama in a stroke and rheumatoid arthritis and presented with the cervical spondylitis, patient presented with the tetraplegia. You look at the patient, a patient has a clearly rheumatoid arthritis, it's most likely patient may well have an atlantoaxial joint dislocation. So don't forget general medical examination. If you are not a good general physician, and you will never be a good specialist. Now, and you have to be able to interpret the clinical findings. Of course, it will come along with the experience and age. Nobody is perfect. I still got my physical interpretation wrong. All you have to do is, and when you do the physical interpretation, and you have to think about it. Oh, I have this abnormality and this abnormality. These two can correlate, or am I getting it wrong? And so you can verify your examination. Next slide, please. Now that is again, I am repeating myself. And when you are taking the history, you can access the patient articulation, and you can just look at it. The patient has a slight facial asymmetry, and etc. of the facial twitching, and so you can do a lot and observe. There is no separate and the history and physical examination. They just overlap. Okay. Uh, Next slide, please. Now, I'm not going to repeat into this, so I'm going to skip this slide. Next one, please. So this is, I just thought this is a good slide. And so you can memorize what olfactory function, what is olfactory nerve, and what is an oculomotor nerve. And some are very basic for some of the doctors, and some are very, so, but this is a pretty basic. So when you look at it, and for example, if you develop the patient nerve palsy, you want to know whether it is a lower or upper motor neuron lesion. So hopefully this slide will summarize the the anatomy of the each cranial nerves. And also, I want to emphasize on the column and this column and the brainstem nucleus, right? So when you look at it, the first and second cranial nerves, they are coming directly from the brain. Okay, it's not from the brainstem. So when the people complain of the optic blindness or olfactory loss of the smell, it is most likely a brain problems, not a brain stem problems. So that is important. That way, I will give you a little bit more example for the next slides. So that is for your mnemonic. And next slide, please. Now, motor. Motor is just a gate, as I said before. And I want to ask you is look at the skeletal abnormality, such as scoliosis. It normally tell you something muscular, long-standing problems. Deformity is always tell you it is a chronic and not acute. Okay, and every examination, like a cardiovascular or respiratory or GI, what you do, inspection, palpation, percussion, auscultation, right? So the same for neurology. You observe the gait and you inspect skeletal abnormalities, or you inspect its muscle wasting. If there is a muscle wasting and fasciculation, it is a lower motor neuron, right? And if there is a contracture, you have already seen the polios and leprosies, and they are telling you it's a chronic. And now the assessment of the muscle power at dawn is a sort of the palpation. So if you do not remember the step in the neurological examination of the motor system, think about how you conduct the examination in cardiovascular and other general medical system. Okay, percussion is a deep tendon reflex. Auscultation is you Oscar the brewery, you Oscar the hot mama. So that you normally observed. And the projectile drift, I have already told you, involuntary movement, like a chorea, acidosis, myoclonus. And I don't expect you to get the diagnosis of the involuntary movements. However, I do expect you to describe involuntary movements. For example, you will describe that involuntary movement is the whole body, including face, or only in the limb, right? And you can also look at it. It's a proximal, like only in the hand, or distal, including shoulders and arm. So describe the anatomical, describe the part of the body involuntary movement, and also describe the speed, a sudden or slow writing movement. So that will give you a lot. If you want to refer to someone else or you want to communicate, it's already tell you, and you just need to describe. Okay, so if you want to ask for someone like a neurology and you can't do the video, and also take the video of the all involuntary movement. Now everybody got a smartphone. So if you don't know, take the video in here. And I am general neurologist, but I sub-specialize in neuromuscular. So although I do treat Parkinson's and other movement disorder, if they are very, very difficult, I have to ask my colleague who sub-specialize in movement disorder. So I have to take the picture with the patient consent, with the video, and look, David, or look, Dominic, look, Jack, what do you think? And they will give you the answer. Okay, so next slide, please. Thank you for the compliment. Uh, Now, reflex, that's a grading, okay? But when you are interpreting neurological signs, none is much specific. You remember in the Wayne index in the thyrotoxicosis, when I was a part 2 medical student, we have to remember Wayne index. And you have a pulse rate and sweating and the weight loss. And why you developed that index? Because no sign is specific. Mini-metastatic score, look into it. They are accessing the different function because no score is specific. So in neurological examination, there are only very few signs are, you can say this is a heart sign. Heart sign means really a pathological signs. So some of the signs are maybe important, but not necessarily a pathological. For example, if someone is very anxious, reflex will be exaggerated. But if you remember clonus, then that is very important. Okay. The next one, please. Now, sensory. Sensory is also, you just ask the patient, touch, pinprick. I normally go through the distal to proximal because if you lost a sensation, you're going to lose from the distal. You're not going to lose from the proximal unless you have a really significant pathology. Okay, for example, if you developed the femoral plexus lesion, you probably developed around the thigh area. But if you have a peripheral neuropathy, most likely develop a TINC, a gloves and stocking neuropathy. Okay. Um, Remember, you have to test Lundberg signs. Why it is an important Lundberg sign is because if the Lundberg sign is positive, patient is at risk of the fall. And so you have to make sure patient not going to fall over and going to have a hip fracture. So it's a risk assessment. Therefore, I'm going to remind you in the initial talk, history and physical examination will help you plan for the management. Next slide, please. Cerebellar, and just think about the drunk person. And I'm not going to tell every sign. Not every patient has all cerebellar signs. So if you have a few signs, for example, like ataxia/speech, not necessarily patient need to have a pendulous reflexes. You does not need to fulfill all the criteria. If your patient is a ataxic gait and a dysarthritis and nystagmus, probably this patient has a cerebellar problems. So look for everything, but don't be put off not having all the signs. Next one, please. Now, formulating the diagnosis is anatomical diagnosis. Single, the examiner is a foot drop. Okay, foot drop. You have to think about whether it is coming from the back or peroneal nerve palsy. Ulnar neuropathy, either at elbow. So that is a single diagnosis. It's normally straightforward, and normally you need to refer to orthopedic surgeons. Multiple, for example, the best example is a multiple sclerosis, but I doubt that you do have in Burma. The best example is someone who has a diabetes, and patient may well have a diabetic neuropathy, and patient may well have a stroke because a diabetic is a risk factor. On the top of that, and patient may well have a spica spondylosis. So that is a multiple. And diffuse, like alcoholic, patient may well have a cognitive dysfunction and peripheral neuropathy. So that is a diffuse. Okay. So when you think about it, it's a patient coming with a single or multiple or diffuse, you can address it. Or sometimes it's like a syndromic, like a dementia or Parkinsonism. Then etiological and pathological diagnosis, because everything has a step. Genetic, you can ask, especially in the neuropathy or dementia like Alzheimer or infection, degenerative. Again, I'm going back to the history. When the history is subacute onset, most likely infection or inflammatory. If it's a very sudden onset, split second, it is most likely the vascular. So you may want to do the echocardiography or just giving for the antiplatelets. Oh, I got a question and answer how I can open it. Okay. Uh, how to, or Rumback signs. You just ask the patient to stand up. You just ask the patient to stand up and ask the patient to close the eyes. If the patient spread his leg or opened his or her eyes, you can say it's Rumback positive. ROMBRGs. Okay. Um, so formulating, for example, that someone got a stroke. That's, oh, this patient got a hemiplegia. It's not good enough. Why this patient got hemiplegia? Is that cerebral palsy? Is that a stroke? Is that a brain tumor? Okay, if it is a stroke, why patient got a stroke? Because patient is taking warfarin. That's why patient got a bleed, or patient got a head injury. Okay, or patient got an embolism. So why the patient got embolism? Because patient got a valvular heart disease. Patient developed the atrial fibrillation and thrombus in the left atrium. So you all need to do pathological, etiological as much as you can. Next slide, please. So I'm not going to talk about primitive reflexes. They are normally, I just summarize it because they are useful for the dementia or the someone talking like a rubbish or not talking to appropriate. And for example, I was trying to be kissed by the MS patient, and because the patient got the frontal lobe inflammatory lesion. So when you do the graft reflex and everything, it is positive, and she or he doesn't develop the really frank cognitive function. So this is important. So just try to make easier for you that one. The next slide, please. So corneal reflex is important. And because if the patient lost a corneal reflex, you have to make an eye protection. Pupillary light reflex, I have already explained to you. Gag reflex is important because if the patient lost a gag reflex, the patient is going to have an aspiration pneumonia. So you have to refer to. Now, cranial nerves, these are the anatomical. So when you look at the brainstem, and I gave you the summary tables of the cranial nerves and how you examine, and then you can look at that anatomical picture. It's not complete, but at least you know where the site of lesion is. So if the patient develop brainstem lesion, or the patient problem is at the brain, or if the patient develop the spinal cord, for example, look at the accessory nerve. If the patient develop the sternocleidomastoid muscles, and the neck weakness, for example, in that case, although it is a cranial nerve, you're not going to, if you scan only for the upper part of the brain, you're not going to find anything. Okay, so next slide, please. So cranial nerve abnormalities, it can be single lesion like an optic neuritis, that, or it could be due to the nucleus. And so that is a explanation for the previous diagram. Or general problems for nerve or muscles, for example, ptosis and myasthenia gravis. And patient, myasthenia gravis patient may develop double vision, diplopia, botulism toxins. They can develop double vision and dystonia. Okay, next slide, please. So that is a summary. If the patient have a combination of the cranial nerves abnormality, you know where you can look at it. For example, third, fourth, sixth, and B1, ophthalmic branch of the B1. And normally they lose the sensation around the eyes, but they don't lose around the cheek or the jaw, because when you look at the fifth cranial nerves, one of the sensory branch go through the cavernous sinus. So when you look at this slide, you can work it out where the site of the lesion. So use this slide and use the brainstem test and use the anatomy, and you can pinpoint where the site of lesion is. And if you can pinpoint anything, ophthalmoplegia everywhere, dysarthria, is most likely myasthenia gravis syndrome. Okay. Okay. Piezo raise hand. What? You can ask me any question, or can I hear you, or you can put on the, I'm not familiar with I'm an old man, so not familiar with the technology. If you want to write anything, you can write or you can talk to me.
He has lowered the hands or mm, he might make a mistake.
All right, okay, that's fine. Maybe the abnormal involuntary movements,
Yes.
right? And pattern of the weakness, pattern of the weakness, and it's a summary, okay? If upper motor neuron, lower motor neuron, or myopathy, they all give you the weakness. Upper motor neuron does not have atrophy, so this is a, now upper motor neuron weakness is a distribution regional. Okay, so when you say distribution regional, and they probably going to weak the whole arm, not necessarily only on the small muscle of the hand. Lower motor neuron lesion segmented, for example, like at the whole forearm, or proximal is a myopathy, normally proximal weakness. In the history, you can always ask, proximal weakness normally asks you to, I can't get up from the bed. If it is a distal weakness, they will say, I got a trip over. Okay, so that is a pattern of the weakness. The next slide, please. I am acutely aware that timing. How much time do I have? And it's a 1 hour slot, or can I have another 10 minutes?
Yes, sir. Yes,
Okay,
sir.
thank you. Uh, so localization of the, why it is important, central, peripheral, combine, and some doctors, not necessarily in Burma, everywhere they don't use their cortex. I wouldn't say they don't use their brain. They use their brain like for like a computer. So they use algorithm, but they don't use their intelligence. For example, if you think someone is an upper motor neuron lesion, you're probably going to scan either CT or MRI scan. But if you think it is an ulnar neuropathy, wasting of the small muscle of the hand, you probably would have scan of the brain. So localization of the lesion. And now people developed wrong attitude. Okay, we're going to have a scan. That scan will tell you the diagnosis where the site of lesion. It is not true, because we always see incidental finding. And some people have an abnormal scan and they never ever had the correlated clinical symptoms. For example, people with the primary generalized epilepsy, not all the patient has abnormal MRI scan, right? And people who never have an epilepsy, sometimes they do have a scar in their brain, maybe the birth-related injury like a forceps. So again, epilepsy is still a clinical diagnosis. So center, if it is a peripheral, you may want to do nerve conduction study or X-ray or whatever it is, depends upon the patient. Combine upper and lower. There are only a few things you can have a combined upper and lower. One is a vascular. For example, patient with a meningococcemia or SLE associated with the systemic vasculitis, they can have a stroke and they can have a vascular stroke around the nerve, or combination of the two pathology like a cervical spondylosis and peripheral neuropathy, or like a B12 deficiencies, and also motor neuron disease. That's all you need to remember. Some are genetic, like a spinal cerebellar ataxia. If you don't know spinal cerebellar ataxia, so what? You're not going to kill anyone. So it's not important to remember unless you wanted to be a neurologist. And some conditions are diffuse, like a hepatic encephalopathy or dementia, other diffuse or metabolic condition, chronic kidney disease, they can give you the diffuse neurological abnormalities. So think about underlying systemic lesion. Okay, and next slide, please. So this is just an anatomical localization just for the material. So I'm not going to explain into details. And next slide, please. So that, again, that is just for the for your reference information. And next one, please. So again, next one, please. And next one, please. Look, now I'm going to talk about this one. Look at it. That is a vascular subline of the brain, like a posterior cerebral artery, middle cerebral artery. Why I am emphasizing this slide? Someone got a stroke, they're going to have a hemiplegia, right? Or someone got the brain tumor, they're going to have a hemiplegia. So how you going to differentiate clinically? Of course, eventually you would need a scan, but clinically, you remember I talked about onset. If it is a sudden onset, it's most likely acute and it's most likely the stroke, especially if patient has either risk factor like a high blood pressure or atrial fibrillation, right? Or patient develop the weakness gradually onset, it's most likely a space occupying lesion. Now, and I'm going to, if patient got the anterior cerebral artery, and they normally give the lower limb weakness predominantly, okay? And if the patient has a middle cerebral artery and internal capsule, they normally use a classic hemiplegic. However, this is a vascular supply, like the one you have an electrical system. For example, this artery, according to the artery neurological deficit where we correlate with the lesion of the brain. So that what we call is a neurovascular syndrome, differentiate. However, that is all down to the blood supply. Blood supply are more or less very consistent, although there are some anatomical variation, anatomical abnormality you could get wrong. But for example, if you get the brain tumor, like this area, can you see me circling it? So in that brain tumor, it's going to give you a neurological deficit, but it does not confine to that area, or that area. So it is a mixed picture of the neurological deficit. So by doing the history and thorough neurological examination, you can diagnose this is a most likely the stroke or this is a most likely a tumor. It's important when you are treating the remote rural area or poor people. Next one, please. So this is a Dametone and a motor system. So I'm not going to, it's a self-explanatory. Now, next one, please. Now, Dametone and myotopes. When you examine the patient and when there is a deficit, you have to think about it. Is the neurological deficit is in keeping with the Dametone, look like an onion skins, okay? Or it is according to the individual nerve. Okay. For example, if it is an ulna, they're going to have just only that one. But if it is a CAD1, it's beyond the wrist. So why I am saying it, If the patient has a neurological deficit as per dermatomes, it is stereo-central. So you want the scan. If the neurological deficit is up to the individual nerve, like a median, like a carpal tunnel syndrome, you probably wouldn't need the scan. So when you are doing the sensory examination, you plot the deficit against the map. Next slide, please. So, uh, so this is also the site of lesion. I'm going to skip it. And next slide, please. Oh, sorry. Can you go to the other side, please? Previous slides. Previous slide, please. Oh, sorry. I didn't talk about myotomes. A myotome is the same principle with the dermatomes. For example, C81 supply median and ulnar, and also finger extension. So if the patient got the weakness in both finger extension, finger flexion, is most likely myotome, so it's a central. But if the patient has only the finger flexor, is most likely the ulnar neuropathy. So if your deficit weakness, sensory is called dermatomes, a weakness is according to myotomes, and you will go back for the central. That's what I mean. Next, please. Next, please. Now, investigation is easy. What I normally say is that you just initially you're probably going to examine pee and poo. ကျွန်တော်ဆိုလိုချင်တာရှူရှူနဲ့ EE ကိုပဲအရင်စစ်ရှူရှူကိုစစ်လို့ C ဂျိုဆိုလို့ရှိရင်အများကြီး information ရတယ်နော် so one is the excretion including sputum of course. Number two is the blood, like a full blood count, and also vitamin deficiency, HIV, but genetic test, I doubt it's available in Burma, so genetic test. And neurophysiological examination, nerve conduction, EMG study, is like a heart disease. When someone got the palpitation, what you do? You look at the sugar and whether diabetic autonomic neuropathy, and you look at the blood for the thyroid function test for palpitation or anemia, and you do ECG. And neurophysiological examination is electrical test like an EEG, electroencephalography, or nerve conduction study. After you do non-invasive or semi-invasive test, what you do is a CSF, lumbar puncture. Then you do imaging, CT, MRI scan, check X-ray, ultrasound, echocardiograph, you name it. So investigation are like a surgical filter, like a other general system, and a biopsy, like a brain biopsy, nerve biopsy. Okay, the next slide, please. So this is a nerve conduction study, and we stimulate the electrode, that you re-recorded it, and we calculated is there any block. So that's just for the picture of the nerve conduction. And the next one, please. And this is an EMG. You look at the tracing of the EMG waveforms, and we decided whether it is a myopathic or neuropathic. And the next one, please. This is an MRI scan. This patient got the patient with the schwannoma, is a peripheral nerve tumor. So imaging. So it's probably this patient developed a brachial plexus lesion, and you can see the imaging. I know everybody know how to scan in their brain, but we do scan everywhere. Next one, please. So again, imaging. And next one, please. Oh, sorry, go back to the previous imaging as well. You can see the muscle signal changes. So like this one, okay? So it's not just only abnormal. This is a biopsy and like a vasculitis. So, okay. Next one, please. Now treatment. There's a specific treatment like epilepsy, Parkinson, but most of the neurological disease need a supported treatment. For example, Guillain-Barré syndrome, they will survive if there's a specific treatment is IVIG, but just giving the IVIG wouldn't save the very severe GBS. So you need the respiratory support, cardiovascular support, nutrition, and prevention of the DVT, and also pain is important. Pain degrades you, so you always up the pain, and then therapy, rehabilitation for the someone who has a foot drop. You need to ask the splint and communication. Don't treat patient as a stupid. Don't treat the patient as a you just listen to me. You have to communicate. And you remember you are a doctor, you are not a god. And we all have a mistake. And I wasn't that nice person when I was practicing over there. And I am ashamed to say that. But you have to listen to the patient. They may not be as educated as you are. They may not be they may be quite simple. They may be scared of you, but in your eyes, their concern is nothing. But it may well be very important for the patient. We all have a teenagers. When we were teenagers, if you have a pimples or spot, ကျွန်တော်တို့ငယ်ငယ်တုန်းကဝက်ချံပေါက်လို့ရှိရင်မျက်နှာကိုကြည့်ပြီးစိတ်မချမ်းသာဘူးဖြစ်တယ်။ငါမဲ့ဝက်ချံကြီးပေါက်လာပြီအယုတ်ကြီးကဆိုးလိုက်တာအဲ့ဒီကလေးတွေကိုသွားပြီးဝက်ချံသိမ်မာမှမဟုတ်တာကွာလို့ပြောလို့မရဘူးလေ။ The same, the patient may well have an unfounded anxiety. Remember, by communicating, by reassuring patient, and patient စိတ်ချမ်းသာသွားတယ် it is a basic values of မေတ္တာ patient ကိုစိတ်ချမ်းသာသွားတယ်အားလုံးပြောအောင်ကတော့မလုပ်နိုင်ဘူး there are some people were unhappy about you and you can't please everyone and anyone but you need to make sure patient is less anxious after you finish your consultation and try positive. Well, you got the dementia, you got the Parkinson's disease, but don't worry, we will support you. We have a lot of the modern treatment. They will help you out. But at the same time, you got to be honest. Well, this is a degenerative condition, so I can't make a medical. ပြောက်အောင်တော့ကျွန်တော်မကုနိုင်ဘူး။ဘာဖြစ်လို့ပြောရမလဲဆိုတော့မပြောက်ဘူး။ပြောက်အောင်မကုနိုင်ဘူးလို့ပြောလို့ရှိရင်လူနာတွေကပြောက်အောင်ကုမယ်လို့ပြောလို့ရှိရင်လည်းပြောတဲ့သူကလူညာပဲ။ I'm always tell the patient the truth ဘာဖြစ်လို့လဲဆိုလူနာတွေကအဲ့လိုဆိုလို့ရှိရင်ဟိုသွားမယ်ဒီသွားမယ်ရန်ကုန်နဲ့တွေ့မယ် ethical မရှိတဲ့သူနဲ့တွေ့မယ်တွေ့သမျှ scan တော့ the whole body scan ရိုက်မယ်ရှိတဲ့ပိုက်ဆံစုဆောင်းထားတဲ့ပိုက်ဆံလေးတွေအကုန်သွားမယ်လုံးဆရာမလို့ဘူး you just need to be how can I say တေးသေးချာချာအေးအေးဆေးဆေးနူးနူးညံ့ညံ့နဲ့အမှန်တရားကိုပြောလို့ရှိရင် you are helping the patients not necessarily you can cure the patient we are not God next slide please final word the same be kind concentrate empathetic don't be judgmental just because of the syphilis or HIV and you can say oh you are နာဘူးကြီးပဲနင်ကသက်စာမရှိဘူးဒီကောင်ကဆေးသမား you are position is not a God you are lucky to be a position to help the patient. So don't be judgmental. And so be aware of your prejudice. And that's it for me. Thank you very much for your attention.